Welcome back. We're going to be discussing Chapter 3 today, which is Lifting and Moving Patients. You might notice that this is from the 14th edition's presentations, and that's mainly because between the 13th edition and 14th edition, there was a lot of changes in terms of how we lift and move patients with spinal injuries. We had a succession of using backboards as a standard care or practice. So we're going to be looking at the 14th edition just because it's a little bit more updated and reflects what we do today in the field versus what we did about 5-10 years ago. So lifting injuries are a huge cause of why people stop working in this field. We discussed in Chapter 2 a lot of the stress things and burnout and all those sources that cause people to leave the field of EMS. But shortly behind that is injury, is what causes a lot of people to end their careers, especially prematurely. We are very prone to injury because of the type of work that we do. And I just want to throw some quick numbers out here. According to the CDC, in 2020, there were 16,900 injuries reported from EMS workers. So those are people who had to go to a hospital to seek care for an injury. Of that, for age groups, 16% or 2,800 of them were less than 25 years old, and 7,000 of them, or 41%, were between the ages of 25 and 34. That means if you were 34 or younger, that represented 57% of the population that was seriously injured in the EMS field in 2020. So this is not a old person issue. Lots of young people get injured, and most of that is due to either lack of physical fitness or lack of proper lifting. Some more numbers. Of all the 16,900 injuries, 5,200 of them were to the trunk, so that's the chest, abdomen, and all the back, including the shoulders and neck. And so that's 31% of all the injuries were to somewhere on the trunk, which is almost always the back. And of all of the injuries, 31% of them, which is 5,200, were directly attributed to overexertion. And that's almost exclusively for lifting and moving improperly. So all this is very important to go over. If you follow these principles, it's what's going to keep you safe and healthy and hopefully have a very long career in EMS. Now, I will point out that a lot of this chapter is hands-on practicality, so it is important to know the textbook stuff that we're going to be discussing this, but most of this content is actual application of it, and we covered that in class of lifting and moving during a skills day. So it's important to actually get your hands on the stuff, and instead of just talking about the theories, actually do these and see your body mechanics change based off of proper lifting procedures. All right, so we're going to dive right in here, going straight into body mechanics of lifting. So body mechanics is the proper use of your body to prevent injury and to help facilitate lifting and moving. Body mechanics as a whole can be the difference between you being able to lift 50 pounds and 150 pounds with the same amount of effort. As long as you use the right mechanics and target the right muscles to use, you're going to be able to lift a lot more and a lot more comfortably and without injury. So the first thing that we have to look at before we're lifting any patient or really any weight of any source is the object itself. Is it something that needs more hands? And this is where, going back to the CDC, talking about the overexertion, this is where a lot of EMS crews are like, well, we don't want to wait for 20 minutes for the fire department to get here. The person's only 300 pounds. I'm sure you and I could do this together. And it's really above the limits of what the two people on the EMS crew can do. And so they overexert themselves and end up hurting themselves. So knowing the object and knowing your limitations is key. And also knowing the limitations of your partner. If you are a very, very in shape person, hits the gym every day, lifts weights all the time, but your partner is 250 pounds and doesn't go to the gym ever, you guys are going to have different limitations of what you guys can lift. So knowing what you can lift and also what your partner can lift is critical, because if your partner can't lift that amount of weight, they're going to end up dropping someone, which will throw your body mechanics out of whack. And going on with your partner, making sure that you have solid communication, especially before the lift, saying exactly what you're planning to do. There's always this clip from the TV show Friends of Ross moving a sofa and just screaming, pivot, 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 pivot. And that's a prime example of a breakdown of communication. But that does happen a lot with EMS, of one partner's thinking one thing, one partner's thinking the other. So discussing even the mode of how you're going to move the patient, and then how you're going to actually execute that in the different stages. Talking about that beforehand and during is key to a safe move. So some rules for lifting. You need to position your feet properly, which is usually shoulder width apart. Use your legs. That's where some of your biggest muscles are around your legs, especially your upper legs with your quads. So we want to capture as much of the leg muscle as we can. Never turn or twist. You want to be going straight up and down, and do not compensate when lifting with one hand. What that is if you're carrying the 30-pound monitor, which is a decent amount of weight, a lot of people will carry it and kind of lean to the other side with their torso, which is compensating for that weight. You want to stay centered whenever you have weight in just one hand. And during class, we actually went over going straight down, straight up. We'll be discussing this a little bit further. Some more rules to follow. Keep the weight as close to as possible to your body. Don't want to be having your arms outstretched, because that's going to target more of the muscles in your arms, which are more prone to fail, especially over the rest of the muscles in your body. And also use a stair chair whenever you're carrying a patient down the stairs or down the stairs. Stair chairs we're going to go over in depth. We're going to use them in class and everything, but they are very, very, very nice to use. Almost all of them nowadays have tracks in the back, which transfers all of the weight of the patient from the chair to the stairs themselves, so that you're not really carrying most of the weight. You're just kind of guiding the stair chair. So whenever we're carrying someone downstairs, try and put them in the stair chair, which distributes the weight to the stairs instead of you, is key. And here's just an example of a crew using a stair chair. This one in this picture happens to not have tracks in the back. This is an older style stair chair. Like I said, almost every agency out there nowadays has a stair chair with tracks in the back. And we went over this extensively during the hands-on portion. Here's an example of a power lift and a power grip. If you notice a power lift, and there's a pointer, in this picture right here, he has his back nice and straight. It's not bent anywhere, especially in the lower back. You can see his bent legs, so all the weight is being carried from the legs. And the load is nice and close to him, so his arms are straight, they aren't outstretched, and the load is very close. So that's the power lift, which we just talked about, a lot of those mechanics. And then a power grip, it might seem silly to say it, but keeping your hands below the object like this, as opposed to over top of the object, that's called the power grip, because your hand is a lot less likely to fail if you have the object in the palm of your hand gripping below it, rather than having your fingertips coming over top of it, because then your fingertips will feel a whole lot easier than your actual palms will. So whenever we're lifting, we want to be using the power lift and the power grip. So a few more things to keep in mind when you're lifting. When you're reaching out, make sure to keep your back in a locked in position. And really that's key for anything with lifting and moving. Once you have started the move, make sure your back doesn't change positions. Make sure it's locked in. Otherwise it could transfer some weight to a muscle in your back, which is much weaker than the muscles that you're using for the actual move. Also avoid twisting while reaching. This kind of goes in with the keep back in a locked in position. You want to be reaching straight out. You don't want to be reaching around something. And avoid reaching more than 20 inches in front of the body. That helps keep you in a power lift, keeping that weight nice and close. And avoid prolonged reaching when strenuous effort is required. So in general, try to avoid reaching, period. Keep things as close as you can if possible. So moving into pushing and pulling, biggest times that we do this is when we're actually moving the stretcher itself. You have one person at the foot and one person at the head. The foot person is technically pulling and the head person is pushing in front of them. So when we're pushing or pulling, push rather than pull whenever possible. So when we're using the stretcher, we a lot of times say that the back is the motor and the front is the steering. So whoever's in the back who's pushing, they're the ones providing the actual power to move the stretcher, and the person in the front is just steering the front of the stretcher around obstacles. That falls right in line with this rule of push rather than pull. Again, keep your back locked in. That's key for any type of movement, is making sure your back's not moving directions at all. Keep line of pull center throughout the body, so you aren't reaching way off to the side while you're pulling or pushing. You're keeping it nice and centered. And again, keep the weight close to the body. As you can tell, most of these principles apply for any type of moving, whether it's lifting, pushing, pulling, reaching. A lot of these are the same principles to keep you from injury. If the weight's below your waist, you should go down to a kneeling position to keep it more centered with your chest. Avoid pushing or pulling overhead, so you don't want to be reaching up because that takes the rest of your muscles that aren't your arms out of the equation. And keep your elbows bent and arms close to your side. Again, keeping all that weight nice and close to you is huge to remember. So protecting your patient, we're going to be discussing some emergency moves, some urgent moves, and some non-urgent moves. So an emergency move, that's when the scene is hazardous or the patient needs immediate care to stop a life threat, or you have to get to other patients who meet those qualifications. So some things that you might use an emergency move for. If you're at a car accident and the car is on fire and the patient's inside, you can use an emergency move to take them out. Another time is if you have 3 unconscious patients from, say, a mass drug overdose, which does happen quite frequently, you can use an emergency move to, one, get to a patient, remove a patient, or move a patient to get to another patient. So the premise of emergency moves is we kind of throw thoughts of aggravating other injuries out the window for an emergency move, as long as it's not something that's going to kill the patient. So if they have a broken arm, we can do an emergency move that might aggravate that broken arm because we're trying to treat an actual life threat. A broken arm isn't going to kill you. So some examples of emergency moves. Right here you have a clothes drag, which is where you can grab the clothes of the patient and just pull them. This is pictured where a guy's pulling the shoulders of a shirt. That's not my preferred way, just because shirts tend to pull off pretty easily. My preferred way, if possible, is if they're wearing pants with a belt loop, is grab a belt loop, which gives you a decent hold, or just the pants themselves and then pull. Because if you're pulling up towards the torso with pants, the pants aren't going to slide off the patient. They're going to be pulling into the torso. Here's another emergency move that you can do downstairs. So you kind of get behind the patient's torso and you grab in between their arms, and then you drag them down the stairs. Always remember to bring the head first towards you, because as you can see, if you do the head second, these feet right here that are dragging would be the head, and you don't want the head banging off all these stairs going down. Here's another emergency move. I personally have never seen or used this one in the field. Some firefighters can use this for an unconscious person. That's why it's called the firefighter's drag. You have the patient on their back and you tie their hands together. You straddle the patient, crouch, pass your head through the patient's tied up arms, raise your body and crawl on your hands and knees. As you can see, this one is pretty complex, and the whole point of an emergency move is it's supposed to be done very quickly and very efficiently. And to me, having to tie a patient's hands so that the knot won't come out, then going through the patient to get proper positioning, then crawling, isn't usually fast and effective. So that's why I kind of like the closed drag over the firefighter's drag. Another one that's really nice if you have the equipment and have the ability to is a blanket drag. So if you can get the patient on top of a blanket, you gather the half that's towards the patient, and then you just drag them with the blanket. Usually they'll stay on top of the blanket. Downsides is sometimes they might slide off the blanket, so it's a little less safe, but it's usually pretty effective. Another one, if they're able to walk, is called one rescue or assist. And this is the typical like sports thing that you see when someone gets hurt and can't use it. One leg is you put a lot of their weight over your neck with your arm right here, and then you kind of walk with them. Similarly, you have the two rescue or assist. Same idea, just you have two people, which helps balance the weight out quite a bit. So that's an emergency when it's a complete life threat. We have no regard to secondary injuries. Our goal is to just move the patient out of whatever's hazardous or whatever is causing it to be an emergency. When it's not an emergency, we then go to urgent moves. So an urgent move is when a required treatment can only be performed if the patient is moved, and some factors at the scene might cause a patient decline. So this is if the car is not on fire, but you need to be able to splint their leg, which has a bone sticking out of it for a car accident. You can urgently get them out because you need to treat the wound and the leg, but it's not an emergency to where we need to drag them out and then aggravate that secondary injury. So an urgent move usually requires us putting the patient on a backboard, and the backboard we use mainly for movement purposes now. For decades and decades and decades, we use backboard as an immobilization tool so that we can immobilize the spine. I'm sure everyone has seen some form of a backboard being used, especially in like football. But now we use it as a patient movement device, so we can slide it underneath them and then lay them down on the backboard, pull them out, strap them in. Then you have handles all around the patient, and you can pull them out relatively quickly. So a non-urgent move, that's when there is no immediate life threat at all. You can assess, treat, and move the patient in a normal way. You can take your time. And that's when we can really, again, take our time and look at anything that we need to be cautious of to not aggravate an existing condition. So if you have some sort of concern for neck pain, so you might be thinking that they have something wrong with their C-spine, or if you have that broken arm that would be aggravated if you pulled on it, this is where we can move these types of patients. So there's no rush. We can be nice and slow and methodical with everything. This is 95% of our calls. We can use a non-urgent move because we have the time and seconds aren't going to matter. So some patient carrying devices. Every ambulance has a stretcher on it. That's how we secure our patients to go to the hospital. There's a bunch of different types of stretchers. The broad term we use for the normal stretcher that you think about in the ambulance is called a wheeled stretcher. And of wheeled stretchers, there's a few different types. There's what's called a power stretcher that has hydraulics in it, so you just push a button up and down, and it's going to raise the stretcher up and down with that push of the button, uses battery power. You have manual stretchers, which that's where it's manually operated. There's a pull handle, and both you and your partner have to lift up on the stretcher and in order to raise it up, and then you have to lower it yourself. So it's all done with human power. And then there's bariatric stretchers. Bariatric stretchers are typically much wider, and they are rated to carry a lot more weight. Usually it's 800 pounds or more is what a bariatric stretcher is used for. Below 800 pounds, most stretchers will be able to accommodate a patient of that weight. Sometimes it can't accommodate a patient of that width. So sometimes we use bariatric stretchers for the extra width that provides rather than the capacity for weight. And someone who weighs 400 pounds could be 4 feet wide, and they won't fit on our normal stretchers. So here's just a picture of a wheeled stretcher being used. It looks like this one is a power stretcher, which is becoming the standard for most places nowadays. 10 years ago, manual stretchers were at most companies. There's only the rich and glamorous agencies that had power stretchers. But nowadays, almost every single ambulance company does have a power stretcher. And some even have what's called a power loader, which is where you put the patient in the vehicle and it's going to load the stretcher for you and carry all the weight for you. It's a secondary device. And probably give 10 more years and that's going to be the standard that we find out in the field. But right now, it's only select ambulances will have it. Here's another picture of a power stretcher. This one is designed by a company called Furno. And here's a picture of a bariatric stretcher. As you can see, it is much wider and accommodates this patient who's very wide. And as the slide says, it's designed to transport people who are very obese to the hospital. Sometimes you have ramps and you have ambulances designed specifically just to carry bariatric patients. So as you can see, this guy is being slid up a ramp right here instead of having to fully lift the patient with just the crew members. And you can see that this stretcher has a big pulley handle here and a big pulley handle here just to help with the fulcrum of weight to make it easier on the crew. So some other patient carrying devices that we use, stair chair, which I've mentioned a few times. That's what we use to get downstairs. It's a chair. The name is pretty descriptive of what it does. And like I said, most of them nowadays have what look like tank tracks on the back, and that's what's going to rest on the stairs themselves and transfers most of the patient's weight to the staircase instead of for you guys. Then you have spine boards. You have short boards, which used to be all the rage 10, 20 years ago, especially with someone who was sitting down to help immobilize their spine. Nowadays, it's almost never used. I personally have never used a short spine board. Then you have a long spine board or a back board. And as it says, it's primarily for removing a patient from a vehicle, especially when we have a neck or spine injury, because we can slide it underneath their butt and then rotate them and then lay them flat on it, which limits the movement of your neck and spine as we're moving the patient. But once we get the patient to the stretcher, we can roll them off of the long spine board, and that will help with patient comfort significantly. And it's been shown that once they're on the stretcher, there's not significant movement to the spine to where we're really worried about aggravating an injury to the spine. And we're going to discuss that a whole lot more in our trauma lectures. Here's a picture of a stair chair. So as you can see, you have a seat right here. Patient's feet can go here, right here and here. These are two handles that can come out about to there and there. And that, again, just helps make the weight a little bit better distributed. And then here's a handlebar for the back. And that can go up even more. It's usually tucked all the way down into here. This is halfway up. And again, just helps distribute the weight a little bit more. And in the back, there are those tracks I was talking about. This is an example of a company called Stryker, their stair chair. The two big companies for patient movement is Stryker and Furno. Stryker is usually yellow, like you can see here, and Furno is usually red. Definitely familiarize yourself with the equipment that your agency carries, because it can be different, and each company has little nuances that you want to be aware of well before you're actually on a call and have to use it. Here's a couple pictures of some long spine boards. As you can see, a bunch of handles right here. That's the big gaps are for the handles, and these little gaps are for straps, so you can seat belt the patient into the backboard. And there's so many different options so that you can adjust them based off of the patient's height or size. This is helpful, as I said, because it gives a lot of handles to the patient. You can secure the patient to it, and then you can pull them out and get them over some odd terrain without dropping them. A few other types of patient carrying devices are portable stretchers, scoop stretchers, basket stretchers, flexible stretchers, and a vacuum mattress. I will say out of this whole list, The one that is utilized by far the most is a scoop stretcher, which we'll discuss and we'll go over in the hands-on portion quite a bit. A scoop stretcher will break in half, and you can literally scoop the patient up, put it back together, and then move the patient. And also a basket stretcher for people who do fire department related activities. A basket stretcher is what we refer to as a Stokes basket. So it's the same idea as a backboard, have a lot of handles, but it has raised edges so that it's a lot harder for a patient to just spontaneously roll off the stretcher. So right here is a picture of a scoop stretcher. As you can see, there's a crack that goes down the entire middle of this, and these two little metal parts actually come apart, so you can break this into two different pieces, have a patient laying on the ground and bring one piece back in, bring the other piece back in, and snap these two metal pieces back together, which literally scoops them off the ground. Right here is a basket stretcher, or a Stokes basket. As I said, it has handles all the way around. Big difference between this and a backboard is the raised edges, which again makes it harder for a patient to just spontaneously roll. If you're carrying someone for a very long period of time or over a long distance, Stokes basket is usually the better option, especially over a backboard, just because it has that added security of the raised edges. Right here is a flexible stretcher. So you can see it has a metal ring around it to give stability, and then just a canvas that goes across it. These are pretty rare to see in use nowadays. Here's a vacuum mattress. Vacuum mattresses are nice. They're pretty rare to see in the field, but they are nice for people who are injured and can't stand up, and you might have to bring them across a long period of time because once you get them on the mattress, it's very flexible. It's full of kind of air-like substance. It will fill up all the voids in a patient's back or legs or any place like that. Then when you take the air out of it, it forms a very hard surface that's conforming to the patient. Here's an example of it being used. The guy is pumping the air out right here, and so it's going to withhold or it's going to hold its shape around all the different voids that the patient may have. So a few things to think about is, when are we going to be choosing patient carrying devices, and how do we make the right choice? A lot of this really comes down to experience. You'll see different types of scenarios, and you'll find out which types of devices work best for what scenarios. It's impossible for us in class to go over every single thing you see, because new things for calls are happening every single day. I'm 10 years into my career. There's still calls that I have to be thinking, oh, well, what would be the best way to handle this, because I've never seen this before. So it is essential that we know our equipment, we know the tools that we have at our disposal, and we know different ways of how to use them, because that will help us decide, well, in this scenario I've never encountered before, I know this device can do this function, and that can probably work in this specific case. So just some things that you're constantly thinking about. And when you're just on routine calls, you can look around the house and think, well, what if the patient was here? Or what if the patient couldn't walk? Or what if the patient was 500 pounds heavier? What type of things could I do to adapt to make this happen? One thing I always think about in a tight area or like a hoarder house or anything like that is, what if this patient goes into cardiac arrest? Because there's a chance they might in the future, and you might be the paramedic or EMT that has to come in and handle this. So just simply being there before and thinking about that can help you when seconds actually matter for moving a patient. So moving patients onto carrying devices. When you have a patient with a suspected spinal injury, you should be immobilizing the head, neck, and spine before the move. We tend to really focus on the C-spine, which is the first 7 vertebrae of the spine. It's mostly your neck. So we don't want to be moving the neck around excessively. The older thinking was we don't want to move any part of the patient's body if there's a spine injury, because we don't want to aggravate it. But it's been pretty well proven that all the vertebrae below your neck once they're injured, it's hard to injure them further. I think it's 98 to 99% of all spinal injuries below the neck are complete when it first happens. So we're much more worried about the neck, which moves a lot more than the rest of your torso. So you can perform manual stabilization of the neck, which is kind of holding the head still so the neck doesn't move. Place a rigid cervical collar that takes the place of manual stabilization because it makes it so the neck stays in the same spot. And then overall, restrict the movement of the neck and the spine. When you have a patient who does not have a spine injury, you can do what's called an extremity lift. That's what we can do from the ground to the stretcher or stair chair, or it can be used from the ground to just a sitting position. So pulling on their arms, pulling on their legs, and I believe there's a picture of that coming up. Yep, right here. This is a full-on extremity carry. So you have this rescuer with his hands underneath the shoulders, and then you have this one between the legs and wrapping around the legs. This is an okay method to use for a very short period of time, and usually with lighter people. I only usually do something like this when it's like an elderly female who weighs 80 pounds. But the big thing is you don't want to do this for a long period of time. This is usually you pick up and you move 1 foot, or you just pick up straight onto another carrying device like a stretcher or stair chair. You aren't doing this to bring them 30 feet. So another method is what we call a direct ground lift. That's going from the ground to the stretcher. And here's an example of the direct ground lift. You can see right here, there's a picture of it. And you have the stretcher set as low as it can go. That means that you're lifting as little as possible. And place on the other side of the patient. You guys face the patient. This is a 2-person maneuver. Drop to one knee. And if possible, place the patient's arms on their chest. Sometimes you can tie the hands together. The head end rescuer cradles the patient's head and neck by sliding an arm under the neck and grasping the shoulder on the other side. And then the foot end EMT slides one arm under the patient's knees and the other arm above the patient's buttocks. And then if you have a third person, the more the merrier for something like this. And you can have them go to the waist. You can have another person actually secure both sides of the feet. You're just trying to get underneath the patient to lift them straight up. So this is the next move of a direct ground lift. You have that communication together, and you guys both lift straight up. And then have the communication to go towards the stretcher and roll the patient onto the mattress. It's usually not nearly as controlled as it's shown in these slides, just to let you guys know. But we will go over all this stuff in the actual hands-on portion of the class. And then some other methods that we can use. These are, the first one is probably the most common method that we use. It's again for a patient with no suspected spinal injury, and it's a draw sheet method. So a draw sheet method is when you have the patient actually in a bed already, whether that's a hospital bed or a bed at assisted living or just a bed in a home, and they aren't able to move from that bed. Usually they are on some sort of sheet. So if you get that sheet unsecured from the bed, then you have kind of, if you remember back to the emergency moves with the dragging motion that we can do, this is the same idea. You have the patient on the sheet, and if you pull the sheet, the patient should come with them. So as it says here, loosen the bottom sheet of the bed, roll it from both sides of the patient, try to get as little excess sheet as possible. Put the stretcher rails lowered, parallel to the bed, and usually relatively the same level or a little bit below the bed. And then you pull on the sheet to move the patient side to side. Make sure to support the patient, especially when they're between this crack here. In real life practice, draw sheet method, usually you have one person on this side, on the stretcher side, and one person over here on the bed side. So you have one person pulling and one person pushing. Again, with this method, the more the merrier. A lot of times if it's in a house, you have only you and your partner, but we use the draw sheet method at hospitals on almost every single call. And in hospitals, we have the hands to help us. And don't be afraid to go chase down some staff members from the hospital to help you move a patient from your stretcher to their hospital bed. So this just shows the recovery position, as we discussed in terminology, which is chapter 5. This is the example of a recovery position, which we want in a unconscious patient. So positioning for shock, for years and years and years and years and years, the position for shock is called the Trendelenburg position, was raise the legs, kind of lower the head, and let gravity rush the blood from your legs, which blood's not needed at the time, into your torso and into your head to where it's belonged. That's been largely proven to be ineffective. So we no longer say to lower the head or to raise the legs. You want the patient to be in a supine position. So you don't want gravity working against you. You don't want them sitting straight up, but you don't need the head lowered beyond the torso, and you don't need the legs up, because that's been shown to not really help anything. So when you arrive at the hospital, as we discussed about a few slides ago, we usually use the draw sheet method. This is called the modified draw sheet method. And as you can see, and as I pointed out with the draw sheet method beforehand, you have the 2 people on the stretcher side, 2 people on the hospital bed side. In this move, the patient's going from stretcher to hospital bed. And so you just have one person on one side pushing, the other side pulling. This helps the patient also not roll off the draw sheet, because you have the physical barrier of the hands here. And as you notice, we're in a hospital setting. We have 4 people instead of just the 2, as I discussed earlier. Get as many hospital staff as you need. It's a lot better than hurting the patient or hurting yourself because you don't have enough hands. So this just kind of goes over them pulling the patient over. And that's a successful move. So some review. So remember, the process of lifting and moving patients is a task that requires planning, proper equipment, and careful attention to body mechanics so that you do not harm your patient or yourself. Because dropping someone will harm them, and it can harm you because your body's going to try to compensate to keep them up. Most important rule in lifting is to lift with your legs, not your back. Make sure to keep your feet shoulder width apart, and keep your knees bent. Rules for lifting are the same for patients as well as equipment, because it's weight. These are rules that you should be using in everyday life. Emergency moves are those that might aggravate spinal injuries, and because of that, we only save them for life-threatening situations, such as a hazardous scene or a life threat to the patient that's actively happening that you have to treat. An urgent move, on the other hand, is used when the patient must be moved quickly. There's still time to provide some quick and temporary consideration towards other injuries or towards a spinal injury. Non-urgent moves are the normal ways that we move a patient. Like I said, the vast majority of our calls, we're using non-urgent moves, and we can do a complete on-scene assessment and restrict movement of the spine if we are suspecting some sort of spinal injury. And positioning the patient for transport, you should take into account the patient's comfort as well as their medical needs and safety. Sometimes you have issues keeping all 3 of those together, especially patient comfort and safety, or patient comfort and medical needs, or medical needs and safety. If you have a very, very anxious patient who doesn't like confined spaces, doesn't like being strapped down, they're going to have a lot of issues with the seatbelts, especially the seatbelts that go across the chest, and that will compromise your safety. So you have to think of patient comfort versus safety. Safety should come above patient comfort, and that's where we should be a patient advocate and explain to them why we have to have the chest straps on to secure them to the stretcher. Or sometimes a patient feels like they can't sit up straight because it puts them in some sort of pain, but they're having a breathing problem to where if you lay them down flat, they're going to start literally drowning in their own fluid in their lungs. And so that's where medical needs kind of will trump the patient's comfort. So it's a well-balanced triad to keep everything in line, which sometimes can't happen. Also, remember the importance of correct lifting and moving techniques on every single call. one call, it can be the simplest call in the world, but one call can end your career. It's a unfortunate reality of our job. It's something I keep in mind all the time. I talk to my wife about it all the time of how I'm frightened that if I do one thing wrong on one call one day, that could be the last call I'm ever able to go on. If I throw out my back just lifting up grandma into the ambulance, that could be the end of my career. So remember to protect your patient and protect yourself from injury to maintain a long and positive EMS experience. Also keep in mind, proper lifting technique is an important wellness strategy. It goes hand in hand with Chapter 2, which was well-being of the EMT. And biomechanics and rules of lifting help prevent injuries associated with lifting. There are a lot of different patient carrying devices. We're going to go over all of them. And you have to choose the correct device based off of the particular patient and the needs of the movement. So knowing all your different devices, knowing what they do, what they're designed for, all the nuances of them is paramount when providing patient care. This is something that we should know well in advance so that we can make a split-second decision on what's going to be most effective. Using proper technique to move patients onto a patient carrying device and positioning them for transport is based upon their condition. This kind of goes hand in hand with the emergency versus urgent moves. So some questions to consider. Why are body mechanics so important when lifting and moving patients? As we've discussed throughout this chapter, body mechanics will target the correct muscles, and the correct muscles can carry a lot more weight. Your quads will carry a lot more weight than your lower back will, just because it's simply much bigger muscles. So being able to use the proper body mechanics will target the correct muscles while we're lifting. Why is using the appropriate patient carrying device an important consideration? So as we've discussed several times, different carrying devices can be utilized in different ways, but they're designed for a specific purpose. A stair chair is designed to bring someone downstairs. If you have a patient that you have to come down a high angle terrain, say it's there on a cliff, stair chair is probably not your best idea because you have to have the patient sitting upright in it. They can't be moving around much, and there's no way to utilize the tracks, which is the main advantage of a stair chair. In that case, something like a Stokes basket might be better because you have a long period of time with uneven terrain, so you want something that the patient can lay down and have raised edges and lots of handles for many people to help. When would an emergency move be necessary? So as we discussed, this is when there's some sort of hazard to the patient, you, or both, or there is some sort of life threat that you have to treat immediately with the patient and you have to move them in order to treat it. In what ways can proper positioning help a patient's condition? As I mentioned a few minutes ago, a lot of difficulty breathing patients, having them sit straight up will help a lot because you don't have the weight of their stomach and chest kind of pressing down on their lungs. So that can be a proper position. If someone's unconscious, keeping them in the recovery position so that fluids can drain from their airway helps. So there's a lot of different reasons to have different positions for different patients. We're going to discuss that a lot when we get to different types of medical and trauma emergencies. We'll discuss what the best positioning for a lot of those patients is for transport. So here's a question to consider. You arrive at a vehicle crash and find an elderly driver slumped over the wheel. Upon examination, you determine the patient is in respiratory arrest, but not trapped in the vehicle. What move would be appropriate for this patient? So this particular patient would warrant an emergency move because they're in respiratory arrest, which is an immediate life threat. You have to treat that immediately and get air into the patient. They aren't trapped, there's no hazards around, but you have to pull them out in order to treat the immediate life threat. So that's where an emergency move would be best. You can open the door and drag them out of the car. So that brings us to the end of this lecture. Like I said, most of this stuff has hands-on application. So this was a little brief overview. It definitely doesn't cover a lot, and there's a lot that might be confusing when we're just talking about the theories of lifting and moving. And that's where having the hands-on class time really comes in handy. So if you don't feel comfortable with lifting and moving devices, feel free to see an instructor and we'll go over something with you. And make sure that you go over any lifting and moving devices with your actual agency, and make sure that you know the specific manufacturers that they use and specific devices that they use, because there are some nuances between different manufacturers. That brings us to the end, so hopefully you guys have a good rest of your day.